Wonderful. Good afternoon, everyone. Thank you so much for joining. I'm Federico Aucejo, the chair of the International Relations Committee that is hosting this hopefully wonderful seminar in gallbladder cancer. We'll have a total of three talks, including incidental gallbladder cancer by Dr. Daniel Anaya, non-incidental gallbladder cancer that was originally planned to be given by Eduardo Viñuela, but instead Dr. Eduardo Vega will give that talk. And for last, unresectable gallbladder cancer that will be given by Dr. Mairéad McNamara. I will pass the word to Dr. Eduardo Vega, who will introduce the speakers and expand on the format of the webinar. Thank you, everyone, and I hope you enjoy.
So thank you, everyone, for joining us today. Thank you, the speaker and all participants to the webinar. Without further ado, we're gonna start with Daniel Anaya Science. He's a senior member of the Chief of GI Surgery and head of the Pathology section in the Department of Gastrointestinal Oncology in Moffitt Cancer Center. Daniel, please.
Thank you, Eduardo, and thank you again for the invitation for you and all the organizers. I want to make sure that you can hear me and see my presentation.
Yes. Perfect.
Okay, perfect. Okay, so I'm tasked to talk about incidental gallbladder cancer today.
It looks like we are seeing the presentation, right?
I agree.
Yeah, maybe you can change the splice setting, go there, yeah, and swap.
Okay. Thank you so much, guys.
Can you see it now?
No, yeah, we see the we're seeing the yeah, maybe you have to swap the screen.
Yeah, give me just 1 second.
Yeah, and we are here with Cecilia. Cecilia, you wanna say hello to the people?
Yes, welcome all friends, AHPBA surgeons for this specific topic and very important in the health of the hepatobiliary surgery. Welcome to this meeting.
Super, let's go.
Thank you. Are we ready?
Yeah, we are super.
Can you see it now?
Yes, perfect.
Yes, perfect.
Okay. So a few disclosures and the outline. I'm going to be talking about a little bit about definition, epidemiology, diagnosis, surgical treatment, and just a little bit about multimodality therapy. A big disclaimer, there's limited high-level data. There's not randomized trials telling us how to treat surgery for this type of disease. The majority is derived from retrospective series. However, there's been a lot of efforts, multi-institutional, collaborative consortiums built that have elevated the data and help us kind of define the role of surgery over the last few decades. To start off, we know that gallbladder cancer is a very aggressive cancer with very poor survival. This is a graph from an unpublished paper that we presented in a regional meeting a few years ago. We used the NCDB database to look at overall survival in patients presented with gallbladder cancer. You can see that the 5-year survival is very low. In our group was about 18%. About close to 50% of patients present with metastatic disease in stage 4. And there's very limited curative opportunities, with resection only being offered about 50 to 20% of the patients. So with incidental gallbladder cancer, by definition, is an early disease, and there's clear opportunities for a survival benefit. In fact, when you compare, these are two studies, one from on the left side, multi-institutional, a few years ago, and the other one from a registry. Comparing survival in patients with incidental versus non-incidental gallbladder cancer, and you can see that survival is significantly better for those patients with incidental gallbladder cancer. So with that in mind, let's really define which patients we're talking about. Incidental gallbladder cancer really refers to that cancer diagnosis found in pathology. Oh, I'm sorry, I think there's a little. Can you hear? Yeah.
Yes, now we can hear.
Okay.
Maybe Jill, can you mute everyone that is not speaking, please? Okay,
Good.
Continue.
So which patients do we refer to? It's patients with cancer diagnosis found in the pathology specimen after cholecystectomy performed for presumed benign disease. So it doesn't apply for patients who had surgery for a mass in the gallbladder or who had surgery for really inflammatory areas that we don't know if they're cancer or not, like Mairéad syndrome and so forth, because those patients present in a very different way, and all that presentation features actually are associated with worse prognosis and different management algorithms. So very important that we know what we're talking about when we talk about incidental gallbladder cancer. And it's actually the most common presentation that we see nowadays, at least in Western countries nowadays, about 0.2 to up to 1 every 1,000 patients of having cholecystectomies present with gallbladder cancer. In some series even higher, up to 3%. And among large series with incidental gallbladder cancer, up to 15, up to 72% of patients, it was diagnosed as an incidental gallbladder cancer. So it's really becoming a very common issue, mostly because of the increasing performance of laparoscopic cholecystectomy. And in the last, in the figure down below, you can see this is from a systematic review. You can see in those patients presented with incidental gallbladder cancer, they present at different stages, with the vast majority having a T2 disease at presentation and the other half between a T1 and a T3, but very rarely they present with carcinoma in situ or T4 disease, because by definition it's incidental. So by definition, the diagnosis is made histologically with the pathology specimen showing adenocarcinoma. I think one of the key important things is that the histologic examination is not only critical for diagnosis, but it's also critical for staging, prognosis, and treatment. All the treatment really algorithm is based on this preoperative staging. And there's a couple of studies that have looked into that, one from the Netherlands, another one from France. And both of them have shown that there's actually very minimal information in the typical pathology reports of the cholecystectomy specimen. In some cases, up to only 10% of patients have important feature reporting. Many times there's missing information or even inaccurate information when this is reviewed by an experienced pathologist. And only 30% of patients in these studies actually had the staging, the pathologic staging reported in the pathologic report. This is very important, like I said, because the treatment is based on that. So the recommendations by the NCCN and what we do basically in every day when we see a patient is we need to, number one, review the pathology, not only the pathology report, but actually the slides, ideally, in which we are going to confirm the diagnosis of adenocarcinoma, determine the wall involvement, the level of involvement, like the pathologic T stage, determine the tumor site in the gallbladder, is it in the peritoneum surface, or is it on the hepatic side? And then three important features in the pathology that are going to guide our management. One, is there a radial margin that is positive? And two, is there a cystic duct margin that is positive? And three, were there any lymph nodes in the specimen? And if they were they positive or not? This is going to impact critically the algorithm that we do for managing these patients. And it's also important because that's the way we stage patients. You can see here on this table on the right-hand side, the 8th edition, which is the current edition, basically it uses all the information that I mentioned. The difference with the 7th edition is primarily based on two changes. One is the T2 staging is now categorized into T2A, those with peritoneal disease, and T2B, those with hepatic site disease. This is because those with the hepatic site had worse prognosis. And then the N category, which was initially determined by the definition of the regional or distant lymph nodes, is now defined by the number of positive lymph nodes, 1 to 3 being N1 and more than or equal to 4 being N2. So very important to understand that. But having said all of that, once we see the patient and we gather all that information, the first thing we do is, like any other patient with cancer, we stage them and we start with blood work, which includes chemistries, in particular LFTs, to determine the liver function, to see if there's any jaundice, either obstructive or maybe from risk factors, patients with PSC or something like that, that can increase the risk of having gallbladder cancer. We always do CEA and CA 19-9. There's controversy on this, but I think it's helpful, particularly for determining which patients are more high risk and also for determining surveillance after treatment. But it's really the imaging, what's the primary mode of staging and for surgical planning for these patients. And based on that, we always, with an incidental gallbladder cancer, we only do a CT chest, abdomen, pelvis, which ideally is multiphasic and contrast enhanced. And we focus primarily on three things: the gallbladder fossa. Is there any soft tissue, anything that could tell us that there's a residual mass? Number two, are there lymph nodes in the periportal area or in the retroperitoneum, particularly in the periaortic area? And then we rule out metastatic disease, looking at non-contiguous portions of the liver, the peritoneum, and the lungs. Having said that, this is different to when you diagnose a patient with gallbladder cancer before surgery, because a lot of changes you may be finding in these CT scans are based on postoperative changes. So, the most common thing that we will see if it's truly an incidental gallbladder cancer is just postoperative findings like a little bit of a seroma in the gallbladder fossa and nothing else. The role of PET or EUS and biopsy is very limited for incidental gallbladder cancer. These are helpful tools, particularly for gallbladder cancer diagnosis when it's before surgery. But in incidental gallbladder cancer, we'll use it for very specific circumstances. For example, doing a biopsy of a very suspicious lymph node, for example. But it's not something that we do routinely. And I would add that in addition to the regular staging and having a good review of the pathology report, and it's important to do two other things. One, to try to get a hold of the pre-op scan, the one that the patient had, if they had one, before the cholecystectomy. Because this is going to help you determine if some of the findings that you're seeing now were there before or if they're just post-surgical. And number two, is going to be very important to understand the surgical details of the cholecystectomy procedure. What were the indications? Was it an emergent surgery versus an elective surgery? Was there perforation? Was there a complete resection of the gallbladder? Was there spillage of bile? That's all very important because in addition to the typical staging features, the T, N, and M, there's other important features that we find that are very important prognostic factors. Number one, jaundice. Patients with gallbladder cancer presenting up to 30% of the cases with jaundice, which is a very poor prognostic factor, usually associated with poor survival. Occasionally, you can do surgery for these patients, but it has to be in very highly selected patients. And in those very selected patients, you could potentially actually derive a survival benefit with surgery with improved median survival, much higher than the 14 months that I mentioned there. Perforation and spillage happens in up to 70% of the series that look at incidental gallbladder cancer. So it's also very relevant. It should be sought after in the op report or with the surgeon by communicating with the surgeon that did the cholecystectomy, because it's also a very dismal prognostic factor. The median survival in patients with spillage is significantly lower than in those without spillage, and the risk of peritoneal carcinomatosis is very, very high, in the order of 25% versus 2 to 3% in patients without spillage. And then, of course, the evidence of residual disease or a positive margin, that is also a predictor of worse survival, 5-year survival in the order of 20% versus 40 or 50% for those without residual disease. So all these are very important prognostic factors. And then once we've gone through all of these, then, how do we do the surgery? What's the role of surgery and the role of resection? And the rationale is basically twofold. One, we want to make sure that we remove all the residual disease. And for that, we need to understand the risk of residual disease and where it might be. And number two, is there a survival benefit that we're giving the patient by doing this procedure? And theoretically, by clearing all the local and regional disease, we potentially can impact the ability to control the cancer and ultimately improving survival. But in the worst case scenario, we're actually improving the staging process as well. That will help us counsel and decide further treatments for the patient. Of course, this is all weighed against the risk, and resection must be safe. And to be safe, it has to be done at a place and with a surgeon with the expertise, not only to do the procedure and the recovery, but also to select patients the appropriate way. So in regards to residual disease, how do we determine the risk? This is a landmark study, multi-institutional study published over a decade ago, but I think it still holds, and multiple other studies have shown the same. In patients with incidental gallbladder cancer, the incidence of residual disease is in the order of 40 to 60%. And it's primarily affected by the T stage. You can see on this table that disease at any site in T1 tumors is 37%, T2 56%, and T3 up to 77%. So clearly associated with that. There's actually a US consortium of biliary tract cancers that was developed a few years ago. 10 institutions collaborated with their data, and they came up among multiple other studies with the gallbladder cancer risk score that also focuses on determining the risk of residual disease. And it not only uses the T stage, but it also uses grade, lymphovascular invasion, and perineural invasion. And you can see on the table on the left-hand side, there's basically 3 risk strata: a low risk, intermediate, and high risk. And it's important because for those at the low risk, there's essentially 0 chance of having residual disease. And some of the T1B patients that we actually propose to have surgery for fall within that category. So it has the potential to maybe decrease the need for surgery or better guide us in the selection of patients that may benefit from surgery. Now, I said the rationale for surgery is residual disease, removal of residual disease. The second one is to do it if we actually think that there's going to be a survival benefit. So this is another landmark study from a cancer registry in France, close to 300 patients. You can see on the left curve the survival based on resection versus no resection. No, when we're talking about resection after the cholecystectomy. And you can see that in this case, those having resection had much better survival. In the right-hand side, you can see among those that had resection, the survival was better in those without residual tumor. And we know that we talked a little bit about that already. And then they actually did it by staging to make sure that the result wasn't confounded by different compositions or proportions of patients by different staging. So on the left-hand side, you can see patients with T2 disease. The upper curve, it shows the survival of those having resection, and the lower curve, those without having resection. So clearly a benefit on T2 patients as well as T3 patients. This was also looked up using the SEER Cancer Registry here in the US. So in the left-hand side, you can see for T2 patients, radical surgery versus just the cholecystectomy, and for T3 patients the same way. And you can see that there's clearly a significant improved survival for those patients by stage. And in a similar study using the same database, the same registry, compare these for T1A and T1B tumors, you can see that there was a survival benefit in patients having radical cholecystectomy and lymphadenectomy in T1B tumors, but this was not significant in T1A tumors. This is another study that they did a decision analysis, a Markov model, and they actually showed that I'm going to draw your attention to the right-hand side of the slide. The left figure shows that by age, so you can see on the x-axis the different age category from 20 to 100 years old, and on the y category you can see the years of life after diagnosis that you earned. The lower curve is no further surgery, no resection, and the upper curve is with resection. So clearly there's a benefit with resection for T1B tumors. That benefit is higher for younger patients, of course, than for older patients. So now that we clarified in which patients and why we need to do the surgery, then there's a few issues about how to do the surgery, the extent of resection. This is a paper from the Memorial looking at the extent of resection. On the left-hand curve, you can see that there was no impact on doing a major hepatectomy versus no major hepatectomy on survival or doing a common bile duct resection. It was really the issue of completing an R0 resection. This is a study from the US consortium in which they looked at the role of common bile duct resection. And in the middle of the slide, you can see the multivariate analysis showing that bile duct resection was not associated with improved survival. In fact, on univariate analysis on the left-hand side, you can see that the survival was a little bit worse in those having common bile duct resection. That study also showed that common bile duct resection was not associated with higher yield of lymph nodes or survival benefit. And because of that, we don't do common bile duct resection only when we need to have an R0 resection, like in the cystic duct margin being positive or something like that. Lastly, I want to talk about role of portal lymphadenectomy. It's primarily for adequate staging. Again, you can see that the incidence of lymph node disease for T1 tumors is 12%, for T2, 30%, and for T3 up to 45%. There's a study from Memorial that was published almost a decade ago, 122 patients. They showed 34% lymph node involvement in incidental gallbladder cancer. Interestingly, they found that when they did the portal lymphadenectomy, the median lymph node count was 3. And in those patients that had no involvement of the lymph nodes, the median disease-specific survival was higher for patients that had more than 6 lymph nodes, as opposed to less than 6 lymph nodes. And this was a landmark study that came up with the new kind of definition of ideally getting at least 6 lymph nodes when you do a portal lymphadenectomy to really make sure the staging is appropriate. Having said that, I would emphasize that in that same study, the median number of lymph nodes was only 3. And when you look at data from the National Cancer Database or from SEER, you can see that a good proportion of patients are NX, and that not having a lymph node dissection is associated with worse survival, probably because they're not well staged. And in those registries, only 35% of patients had lymph node dissection, and only 6% had more than 3 lymph nodes in the specimen. So clearly, we recommend doing a complete portal lymphadenectomy, but the reality is that that benchmark of 6 lymph nodes is hardly ever achieved. So with that in mind, we in our group kind of created a technique to try to optimize this. This is basically focusing on nodal basins 8 and 12 A, B, and C, and P. And we identify 6 different packages based on where they're located when you do a portal lymphadenectomy. This is the axial view across the lower part of the hepatoduodenal ligament of all the different packets. And we basically, name this because we use a clockwise, anterior to posterior, and double isolation approach. We start by opening the peritoneal package by taking this packet 1, which corresponds to lymph node in nodal basin 8, and then we open in a clockwise fashion the peritoneum, and start taking the packages in the anterior compartments, package 1, 2, and 3. Then we do a double isolation of the critical, the left hepatic artery with the proper hepatic artery and the bile duct and the hepatic duct, and that allows us to take the packet 5 and 6, which are more in the posterior compartment. And this is how it should look. At the end of the procedure, basically, you should only see the named structures going into the hepatoduodenal ligament. We published this year 71 portal lymphadenectomies for gallbladder cancer, and our median yield was 5. So it was higher than what's been published in many papers, but it still didn't reach 6. It was about 40% of patients that had more than 6 lymph nodes. Very important to understand. However, it was safe with using this technique, no change in the outcomes. The only thing that was different when we compared all the liver resections that we did to about 500 liver resections without portal lymphadenectomy and adjusting by different factors, it only increased the OR time by about 46 minutes, basically to do this portal lymphadenectomy. We thought it was a reproducible and easy to learn, easy to teach technique. So I think that's all I have. I want to add 2 slides for a lot of strategy, surgical strategy, and relevant issues that I didn't have the time, and maybe we go into the questions. Lab versus open approach is no difference in survival. Timing, this is a controversial issue, but ideal is done between 4 and 8 weeks after the patient had the cholecystectomy. Staging laparoscopy, we do it selectively for patients with high-risk disease. Port site resection is not needed anymore because it's really a surrogate of peritoneal disease, not really an impact on survival. The cystic duct margin being positive It's an ominous sign, and it's something that if you're required to do a common bowel duct resection to obtain an RCA resection, is recommended, and it's associated with improved survival, and some of other issues about what to do when you find the tumor. And then multimodality therapy, you have to understand that recurrence rates are high. They can be up to 6%, 60% at 2 years. The failure pattern is usually 50% local regional, even in the context of portal lymphadenectomy, and 50% either distant or combined. Because of that, the current standard is adjuvant chemotherapy following the BuildCap trial data. And you could argue that chemoradiation for patients having R1 resections. And an issue of current study is the role of neoadjuvant approaches in high-risk patients. There's the first ever phase 2/3 trial on neoadjuvant approach for gallbladder cancer specifically is being conducted currently. And we are excited that that's happening and look forward to those results. So in summary and conclusion, gallbladder cancer is a highly aggressive cancer with poor outcomes. Incidental gallbladder cancer is increasing as the most common presentation. It has better prognosis and potential for survival benefit, even cure. However, the diagnosis and the adequate staging are mandatory to guide treatment. Surgery is focused primarily on liver resection and portal lymphadenectomy, with the goal of obtaining an RCA resection. No need to do major hepatic resections just because. You just need to have the goal of getting RCA resections. And the surgical strategies have evolved and are better defined nowadays, thanks to many larger studies, multi-institutional, such as the consortium. And prospective trials and collaborative efforts like registries are still needed, particularly to define the role of specific therapies like adjuvant and neoadjuvant therapies. And with that, I'll finish, and we'll be happy to take any questions either now or at the end of the session. Thank you very much.
Thank you, Daniel. That was an amazing presentation. I think because of the time, probably we're going to take all those questions at the end. So for everyone who is in the webinar, hold your question, and we can actually ask those questions at the end of the panel. Is that okay, Cecilia?
Yeah, yes. And finally, it's better. Yes.
Yeah, super. So Eduardo couldn't be here today, so I'm gonna share his slide, and I'm gonna present next. You see well the presentation?
Yes.
Yes, perfect. So I'm gonna talk about non-incidental gallbladder cancer right away. So gallbladder cancer, we know already, rare disease. However, it's the most frequent biliary tract cancer. And it has this particularity that it has different incidence depending on the region. So have geographic difference. Very important for South America, Latin America, is how incident is is more than 50% high compared to the global standard. And Chile is one of the most high incident of gallbladder cancer. Risk factor, as we know, is age. Female are in between 4 times or to 2 times more to have gallbladder cancer. There is still the pathologic risk factor of gallstone and chronic cholecystitis, aflatoxin exposure, pancreatobiliary maljunction, probably more in Asia, and some infection-related etiology has been studied in gallbladder cancer. This is a recent paper from Dr. Roa from Chile, and in collaboration in Natural Review. I invite you to review it. This is the most prevalence etiology of gallbladder cancer. This is a metaplasia, dysplasia, carcinoma, related most of the time by inflammatory chronic disease. And then the unique adenoma carcinoma that is not related to gallstone, and it's more prevalent. It's more prevalent in Asia population. This is the experience of Hospital Sotero del Rio when where Eduardo worked. and has developed the entire experience of gallbladder cancer. He's claiming here most of what Daniel already present, that non-incidental has worse prognosis compared versus incidental gallbladder cancer. And this is a series of more than 600 patients. Professor Blattlock say at some point in an early time that if malignancy of the gallbladder can be diagnosed without exploration, there is no role for surgery in those patients. However, we have to understand something. When we compare incidental and non-incidental gallbladder cancer, there is for sure a bias of selection. Incidental patients for sure are going to be more early gallbladder cancer. However, when we compare the same type of population, again, in a non-incidental gallbladder cancer, we take out the T1, T4, and the incidental gallbladder cancer, we most likely take one T1, and we avoid the preoperative jaundice or other adjacent organ resection. We know that actually in T2 gallbladder cancer, incidental versus non-incidental gallbladder cancer, they don't differ too much between each other. In the Hospital Sotero del Rio, Santiago, they have 10 years of experience for 459 patients and reach elective surgery 36 patients. So that's something also that have to highlight. Most of the patients who are diagnosed as a non-incidental gallbladder cancer, yes, half of those patients do not reach surgery. And only 22 to 80% of those patients achieve R0 resection. 22% of the elective patients who reach surgery, and 8% of the population who actually was originally in the review. Most of the patients will reach palliative or R1 resection. And you would say, well, R1 resection is not that bad. But in this graphic of the survival in the historic cohort of Hospital Sotero del Rio, Chile, we can see that R1 resection is not much different from R2 resection. So when we talk about non-incidental gallbladder cancer, we have to understand, as Daniel was mentioned, that we may have to play a role between liver resection, how much liver, lymph node dissection, how many lymph nodes, is it worth to have the bile duct resected, or in the non-incidental cohort of patients, most likely we could have also adjacent organ need of resection. Lymphadenectomy, or the old classification was related to localization of those lymph nodes. That's a change, and now it's the number of lymph nodes. But if you have distal lymph node, the survival of this study, if you have distal lymph node, the survival is pretty much as a metastatic disease. That's, we already know that. Eduardo wanted to show us a little bit about how do they do in open resection, the lymphadenectomy. They probably have the same standardization that Daniel was kind to show. And then you have the other option, the biliary drainage on jaundice in this specific cohort of patients of non-incidental gallbladder cancer. However, patient with jaundice, meaning malignancy jaundice, had more major resection, more common bile duct resection, more lymphovascular invasion, that is a worse prognosis, and less R0 resection. And if you think that if you drain those patients, you'd actually do some deserve on the survival. This study recently published by the group of Dr. Polik showed that if you train those patients or if you don't train those patients, survival, long-term survival will be the same. So I don't know if that was a stress in this study, but I think it put a careful comment about doing those bypass, biliary enteric bypass in advanced gallbladder cancer that are not going to get resected. The experience of Hospital Sotero del Rio, primary gallbladder cancer, non-incidental, and jaundice, patients who actually reached curative intent surgery, only 20 in almost 15 years. R0 resection from those 20 reached in 65%. However, mortality was 5%, but more significant, morbidity is 78% of those patients, and 25% of those patients require reoperation. And again, the median overall survival, you can judge that by yourself, is only 11 months, with 8% of 5-year survival. In Chile, we have this specific type of gallbladder cancer, and it's actually been calling the Chilean clasking. It's when the invasion of the tumor reach the common bile duct, and not only that, it's mimic what it can also take into confusion as a clasking type of tumor, and that would require a major resection, a major surgery, when we don't have a biology that is exactly the same like a perihilar cholangio. So you have to take into account that. And we know, again, the same demonstration that Daniel already commented, that is not higher disease specific survival for common bile duct resection, standardized common bile duct resection, and do have severe morbidity. So resection of the bile duct, routine resection does not cure more patients. It does not lead to more node harvest. It increases morbidity and mortality. So when to resect? In select patient only, right? When we have a clear direct invasion, and only that. When we have a positive cystic duct margin in the resection of the cystic duct margin, if it is an incidental gallbladder cancer, or if it is a non-incidental gallbladder cancer, if you have a positive margin in the cystic duct, but also in select type of patient. Those are the adjacent organ that we have for gallbladder cancer. The most frequent though is the duodenum, but we could talk about colon resection, duodenal resection, and common bile duct resection. And in the new classification, one organ resection is still T3, and more than one, it will be a T4 tumor. So what about the duodenal duodenal invasion? This study showed 43 patients with duodenal invasion. Arterial resection was achieved in only 62% of those patients. Most of those patients require partial resection and primary closure. 9 cases require distal gastrectomy. But the most important point, I think, about all the statistics is that if you have gastric outlet obstruction, only 10.5% of those patients reach resectable surgery. And yet, again, mortality is 7 and morbidity is 35, and the median overall survival is still 14 months. So again, selection, careful preoperative planning, study imaging, endoscopy, and colonoscopy. Those patients who had non-incidental advanced gallbladder cancer should have endoscopy and colonoscopy, because it's also not clear in the CT scan whether the duodenum will have to be resected. And the sensitivity and the specificity of the CT scan for that is about 76 to 81%, and the specificity is only 85%. Be strategic, use intraoperative ultrasound, and you have to be open to change your plan of resection. Again, we will see whether major liver resection make any difference in survival. And this is a Japanese study. However, it's a 2010, 149 patients. They tried to divide this for having stratified by having one of more. This is a hepatic invasion. This is hepatoduodenal, left side of the hepatoduodenal ligament, and lymphadenopathy positive. You can see that if they have more than 2 of these factors, the prognosis is pretty poor. And there is no role for major liver resection in those cases. And those cases are the ones that are going to be more exposure to having selected those cases for major liver resection. So be careful. In conclusion, benefits of radical resection for advanced gallbladder cancer is limited, and patients should be careful study and selected. Extensive resection are not an option if they can be done, are an option if they can be done with acceptable morbidity. Surgery may have reached its limits, and further improvement and development rely in understanding biology, adjuvant and neoadjuvant treatment that we will talk further. Thanks so much. Okay. So without further ado, we have the next presenter that's going to talk about unresectable gallbladder cancer. She's the Mairéad McNamara. She was appointed as a senior lecturer and honorary consultant in medical oncology at the University of Manchester and the Christie NHS Foundation Trust. Please, Dr. McNamara, begin.
Good evening. I'm Mairéad McNamara. I'm a senior lecturer at the University of Manchester and an honorary consultant in medical oncology at the Christie NHS Foundation Trust in Manchester, UK. I'd like to thank the organising committee for giving me the opportunity to speak at this gallbladder cancer webinar, and the title of my talk today is Unresectable Gallbladder Cancer. Here are my conflicts of interest. I will first give you an overview of my talk. I will talk about the anatomical location of gallbladder cancer in relation to the other biliary tract cancers first. I will then give a little bit about the introduction in terms of background introduction into the prognosis for these patients. I will talk about standard of care options for treatment, a little bit about the molecular spectra and what the current guidelines are. In terms of biliary tract cancers, they arise from epithelial cells lining the bile duct and can occur at distinct anatomical locations. And these can include the intrahepatic, so within the liver, extrahepatic, so hilar or the distal bile duct, and gallbladder cancer. So gallbladder cancer is the most common cancer of the biliary tract, and the highest incidence is found in South America and South and East Asia. Gallbladder cancer is usually diagnosed at a later stage with poor prognosis. And this was a pooled patient data set from 18 international first-line clinical trials in patients with advanced biliary tract cancer. There was 1,333 patients included, of which 385 had gallbladder cancer. So this was 29%. If you look at the figure on the extreme right, patients with gallbladder cancer have worse overall survival than those with the other primary anatomic sites, such as cholangiocarcinoma. So the median overall survival for patients with gallbladder cancer was approximately 8 months versus up to a year in those with cholangiocarcinoma. This was a systematic review and meta-analysis that was carried out by a fellow who had worked here in Manchester, and he looked at all the studies reporting patients with gallbladder cancer receiving palliative systemic treatment in any line. There was nearly 2,000 patients included, and the overall radiological response rate was 23.2%, with a mean progression-free survival of 4.8 months and a mean overall survival of 8.3 months. There was a number of different combinations of chemotherapy used, and this figure displays that. The most common combination treatment used was cisplatin with gemcitabine in the purple on the bottom. Gemcitabine oxaliplatin was next, which is seen on the left-hand side of the figure at 14%. And this was followed with the gemcitabine, which is in the green on the right side of the figure at 9%. When we look at the guidelines, the ESMO guidelines have recently been updated and published in 2022. For patients with biliary tract cancer, if you look here in the red boxed area, these are the patients with advanced disease. Over on the left-hand side of the red box, those have locally advanced, and cisplatin gemcitabine plus or minus durvalumab are recommended. On the right-hand side are those with metastatic disease, and molecular profiling is recommended, and this is more pertinent to those with intrahepatic cholangiocarcinoma, for example. On the bottom of the figure, it talks about the different molecular alterations that are involved and what treatments could be considered. I will go into a little bit more detail on this at a later stage of the talk. Looking at the NCCN guidelines for unresectable or metastatic disease, it is recommended, and this is very important, that patients have a biopsy rather than brushings, as then molecular profiling can be carried out. MSI testing is something to consider, and tumour mutation burden testing also, as these patients may benefit from immunotherapy. It is also very important to consider best supportive care if a patient is not fit enough for systemic treatment. So what about in advanced disease? What is the evidence behind the different regimens recommended? In 2010, this study was published. It was the ABC02 clinical trial. Patients were randomized to receive either cisplatin gemcitabine or gemcitabine alone. Patients receiving cisplatin gemcitabine had a median overall survival of 11.7 months versus 8 months with gemcitabine alone. 36% of patients had gallbladder cancer. The hazard ratio for survival was 0.65, so this meant a 35% reduction in the risk of death. If you look at the subgroup analysis for gallbladder cancer, the hazard ratio was 0.61, which was quite similar, so patients with gallbladder cancer derived benefit from the combination, as did the other primary sites of biliary tract cancer. The TOPAZ clinical trial was published this year and was initially presented at GI ASCO earlier in the year. Patients received cisplatin gemcitabine with durvalumab versus gemcitabine cisplatin alone. 25% of patients had gallbladder cancer. The hazard ratio was 0.8 with a median overall survival of 12.8 months versus 11.5 months. What about patients with gallbladder cancer? The hazard ratio was 0.94 versus 0.8 for the entire population. So maybe the patients with gallbladder cancer don't derive as much benefit, but they do derive some benefit. The updated analysis of the TOPAZ-1 clinical trial was presented at ESMO this year, and cisplatin gemcitabine durvalumab did improve survival in the first-line setting over cisplatin gemcitabine alone, 12.9 months versus 11.3 months. Durvalumab in combination with cisplatin gemcitabine received FDA approval in September of this year for the treatment of patients with locally advanced or metastatic biliary tract cancer. What about in the second-line setting in advanced disease? The ABC06 clinical trial was published in 2021. Patients were randomized to receive either FOLFOX, that's 5-FU with oxaliplatin, versus best supportive care alone. The hazard ratio in this study was 0.69, with a median overall survival of 6.2 months versus 5.3 months. However, what was more clinically meaningful was that there was 25.9% alive at 12 months in the FOLFOX arm versus 11.4% with supportive care alone. What's important to note here is that the response rate was approximately 5%, and this is important when I'll discuss the studies using targeted therapies later on. What about the subgroup analysis? So patients with gallbladder cancer did benefit from systemic treatment. The hazard ratio was slightly better at 0.56. But this may be a reflection of selection bias, given that patients who have survived to second-line treatment may do a little better. What about in the second-line setting with the NIFTY clinical trial? So this was a trial that was published in 2021. The median overall survival reported was 8.6 months versus 5.5 months. There was 30% of patients with gallbladder cancer in this study, and the hazard ratio was 0.68. What about the subgroup analysis? Subgroup analysis showed that there was benefit for patients with gallbladder cancer with a slightly better hazard ratio of 0.29, but again, this is probably selection bias in the patients who survived to second-line treatment may do a little better. The updated analysis or final results of the NIFTY clinical trial were published in they were actually presented at ESMO in 2022, and the final results did show the benefit, ongoing benefit of liposomal irinotecan 5-FU versus 5-FU alone, with similar survival readings in comparison to ABC06 clinical trial. So I'm just going to briefly mention this. What about neoadjuvant treatment? So there is no standard neoadjuvant treatment in this setting, but it may be that you referred patients with advanced disease or locally advanced disease who would receive upfront palliative chemotherapy, and it would be important to discuss them at multidisciplinary meetings to see whether surgery may be possible following a number of cycles of chemotherapy. So when you look at the NCCN guidelines, there's no preferred regimens in this setting. There are recommended regimens, which is a broad list. I would recommend overall to consider standard of care, either cisplatin gemcitabine or cisplatin gemcitabine durvalumab, if that is approved in the upfront setting in the first-line advanced setting. When you look at clinicaltrials.gov, there are 4 trials reported looking at neoadjuvant therapy. These are located in Germany, India, Korea, and the USA. The chemotherapies use your cisplatin gemcitabine, except for the one from Korea, where they're using cisplatin gemcitabine in combination with durvalumab. The study in India is also looking at radiotherapy, and these are all in the perioperative setting. It will be interesting to find out the results of these studies, as there is no standard at this point. What about the molecular spectra of biliary tract cancer? We know that patients with FGFR2 fusions and IDH1 mutations do benefit from targeted therapies such as FGFR inhibitors and ivosidenib. These alterations have been identified predominantly in patients with cholangiocarcinoma and predominantly intrahepatic cholangiocarcinoma. But what about gallbladder cancer? So if you look down in towards the bottom of the figure in the green box, you look at the different alterations that have been identified in gallbladder cancer. So specifically HER2 is mentioned here, and I will talk about it in another slide. Over on the left-hand side, I have mentioned briefly BRAF V600E mutations, as there was a trial published in 2020 where patients who had previous treatment and had this mutation identified received dabrafenib and trametinib. These were patients who had received, as I said, previous treatment, and they had a response rate of 51%. And this is just to look in comparison to the ABC06 clinical trial, where the response rate was 5%. So this study looked promising. However, there was only one patient with gallbladder cancer included in the 43 patients that was reported in that study. So what about HER2? What is the evidence to support treatment for those with HER2 alterations? This was a study that was published in 2021. There were 39 patients included. 41% of patients had gallbladder cancer. 5 out of those 16 patients had a partial response. And the objective response rate was 23%, which compares favorably again in comparison to the ABC06 clinical trial. Just thinking in general, then, the overexpression of HER2 in patients with gallbladder cancer has been reported to be approximately 13% in patients with gallbladder cancer from retrospective studies. The figure shows here the overall response and the decrease in target lesions from baseline. So in summary then, what are the guidelines in terms of treatment of patients with advanced gallbladder cancer? So when these patients are assessed in clinic, the first thing to think about is, are they fit for actual systemic treatment? If they are not, then best supportive care may be the best option. For patients that are fit for systemic treatment, locally advanced should be considered for either cisplatin gemcitabine or cisplatin gemcitabine durvalumab, and always go back to a multidisciplinary meeting for discussion in case surgery may be an option. For those with metastatic disease, consider molecular profiling, and specifically MSI and HER2 for patients with gallbladder cancer. If there is a clinical trial, this would always be a good option for these patients. The percentage of patients which will have HER2 alterations, as I said, will be approximately 13%. But at the moment, there is no standard treatment for these patients, and clinical trials would be recommended. The number of patients who have MSI high status and biliary tract cancer is probably less than 3%, but it is worth testing in case these patients may have that alteration and may benefit from immunotherapy. Neoadjuvant treatment isn't standard at this time, and it will be important to get the results from the ongoing clinical trials. Thank you for your attention, and I'm happy to take any questions. Thank you.
Good. So now what I think I'm going to do is I'm going to introduce the panel. The first is my boss, Cecilia Yeren. She's the chief of the pathology service in the Hospital Nacional Guillermo Almenara Irigoyen, and is also the president of the Peruvian chapter of AHPBA. She's going to be with us and probably going to start the round of questions. I also recently noticed that joined us in the webinar, Professor Siri Maitel. He's a professor of surgery of the Division of Oncology and Department of Surgery of Emory University of School of Medicine. And I believe he's the PI of the neoadjuvant trial that is being conducted in North America. So maybe I can start with some question, if everyone agree. I wanted to ask you, Danielle, what is the role of lymphadenectomy in the AHPBA space in your patient?
I thank you, Eduardo. I think to be perfectly honest, we don't do extended lymphadenectomy, so we focus on always doing a complete portal lymphadenectomy following the regional basins that I mentioned, which essentially corresponds to basin 8 and basins 12. Having said that, we always start the operation by doing a frozen section biopsy of the lymph node in station 13 and periaortic, which corresponds to that is station 16. We don't go crazy in doing that, meaning if once we do a complete Cocker maneuver, you know, there's nothing really there, or there's nothing really to identify and biopsy, we stop there, but we try to do that, and it's primarily not as part of the treatment, but we do a frozen section. If it's positive, we would stop the procedure at that time.
Federico, you would do extended lymphadenectomy, or you also do the sampling?
No, I mean, I would limit it to the periportal lymphadenectomy. I wouldn't go beyond that.
Cecilia, you know, in Peru, how are they doing those lymphadenectomy?
Yes, in my service is necessary in extended lymphadenectomy, number 8, number 12 is necessary. But I would like to ask a question. All the panel is very clear lecture. Congrats by the lecture. How about the impact of the pandemic, COVID pandemic, to the gallbladder cancer? Because it's very relationship about the inflammation to the gallbladder. Is the high rate the incidental gallbladder cancer, or how do you think about that?
I can take it from, I'm working in Boston. I think incidence of gallbladder cancer, at least here, is not high. So I wouldn't expect any change from the pandemic related to the incidence of gallbladder cancer. But I think it's something that maybe, Cecilia, you can talk about Peru, because with a high rate incidence of gallbladder cancer country, probably that may change your ability of diagnosis this in an early stage.
Normally in Peru, the two years about the COVID pandemic, there are a lot of cases with gallbladder cancer inflammation relationship stones into the gallbladder. By that specific disease produces a high rate to the gallbladder cancer. Is the same thing? Is the same in the other countries?
Federico.
I wouldn't know, Cecilia, honestly.
Yeah. Yeah.
Eduardo, can I add something real quick?
Yes, please, Professor.
So I don't know any about the disease, actually pathogenesis of gallbladder cancer in relation to COVID, but I will say in the United States, given that 2/3 are diagnosed incidentally, with the incidence of general surgery and laparoscopic cholecystectomy going way down during the pandemic, I feel the diagnosis of incidental gallbladder cancer actually went down. Now, I don't think the incidence necessarily changed, but the diagnosis in 2020 and 2021 went way down. And that was I saw that as a reflection in terms of just the number of cases that we saw at our own institution and the number of cases that we were able to enroll in the trial in those 2 years. And now I see the increase in enrollment happening as more general surgical procedures are being done.
Super. Yeah, a good comment about the trial.
I have a question, Eduardo, if I may. This is a
Yeah.
technical question for Daniel, Shishir, Cecilia. How much of segment 4B5 you take out? Do you do like a formal hepatectomy? These segments, it depends on whether the cancer involved the hepatic side or the peritoneal side of a gallbladder. Do you do a frozen examination of the resection intra-op to determine you go furthermore or not? Do you have a specific approach?
Yes, if in the surgery it's possible, the frozen test is a good idea when the surgeons thinks is a gallbladder cancer. Is the best test.
So you routinely do a
Yes.
frozen intra-op
Yeah.
examination of the liver resection part.
Yes.
You Daniel, do formal or just a gallbladder PET?
Well, you know, if we say a formal of segment 4B and 5 is actually taking the pedicle of each segment, we don't do that. We do a generous non-anatomic resection that corresponds to the area of segments 4B and 5. And we take the specimen to the frozen lab, which is across the hallway, and cut and make sure that there's nothing macroscopic, and with any doubts, we do a frozen. We don't do a routine frozen because the area is generally a very large area, surface area. So it's, you know, it's going to be kind of not really that conclusive or helpful. But routinely for routine cases, we don't do the anatomic, and of course we don't do a major hepatectomy for that. No, we focus on getting an R0 resection.
I have a question for Dr. McNamara, Mairéad. Could you please tell us what is your recipe to start chemo, adjuvant chemo after gallbladder cancer? Let's think about incidental T3 and 1 in a healthy person who can tolerate every regimen. Which one would it be the regimen you're going to offer? Why? And maybe we can go from there. I have many questions about it.
Okay, so I would think, you know, if you're to follow the evidence, which everyone should do, and follow the clinical trials, it would be capecitabine. So for any stage, if it's a gallbladder cancer, there's always going to be a high risk of recurrence. So that you would recommend adjuvant treatment, and it would be capecitabine based on clinical trial evidence to date. And I wouldn't deviate from that.
But
And I know, and yeah, go on.
Yeah, well, you are talking about build cap. 80% of build cap was gallbladder cancer. Sub analysis and multiple massage of the data gives some hope to everyone about capecitabine by himself. Do we have really evidence to talk about gallbladder cancer and capecitabine in an adjuvant setting?
So, I suppose what I would say that most trials that are there, they've never been carried out in just a single biliary tract primary site. So they have always included all of the sites. All of the different primary sites did derive benefit regardless. And in order to recruit to a trial with just gallbladder cancer, it is going to be more challenging. And you have to, I suppose, go with the evidence that's there at the moment. And that is the best, it's clinical trial randomized evidence. And definitely, if you look at the overall survival, even numerically, it's over 50 months overall survival in the with capecitabine versus just over 30 months with surgery alone. So numerically, and it's more clinically meaningful for sure. So you have to go with what we have at the moment, and that's the best evidence at the moment. There is an ongoing trial, ACTICA, which is running in Europe, and patients are being randomized to receive cisplatin gemcitabine versus capecitabine, and actually that's really close to closing recruitment, because we're recruiting to it here in Manchester, and they have stopped taking any more screening for that. So there's over 700 patients included in that study. So we'll be interested to see what that will show, with the combination versus single agent capecitabine as well.
Okay, and why would it be the role of gemabraxine? Does it have any role in gallbladder cancer?
So there's no evidence to say that it does at the moment. So there is a trial that has run and has close to recruitment in the advanced setting, where there's Gemcis nab-paclitaxel. In the US, Rashenschroft is the CI for that. So that has close to recruitment, but we don't know the results, but that's in the advanced setting. So there isn't any evidence in the adjuvant setting yet in biliary tract cancer.
Perfect. Daniel, yes, sorry.
Yes, a question, Dr. McNamara. Here in South America, there are young people with gallbladder cancer. There are different chemotherapy adjuvants by the young people or the elderly people, because there are people, women with 30 years old or 25 years old with irresecable gallbladder cancer. It's possible different chemotherapy or higher level bilirubin.
You're asking if there's different types of chemotherapy depending on age? Is that the question?
Yes.
Yeah. I would say no. It's more about fitness. I would think, you can't just say that you'd give. We don't know whether combination treatment is better than single agent treatment yet, based on the trial evidence that we have. So you wouldn't, anything you would be doing would be not based on trial evidence. So regardless of the age at the moment, we would always, if you follow ASCO guidelines, if you follow and the different guidelines that are available, you would go with single agent capecitabine. I think if you're doing anything outside of that, you are going outside the trial evidence that is available and guidelines that are there.
Okay, thank you.
Perfect. I wanted to change a little bit the topic. Probably perhaps the most difficult scenario that we've been called when we are HPV surgeon is when one of our colleagues, a general surgeon, is doing a gallbladder. And he's noticing that it wasn't actually a stone, it's a polyp. And he's noting that the polyp may or may not have some invasion to the gallbladder wall. I wanted to ask Danielle and maybe Professor Maitel also can comment with Federico. How is their approach in those cases, and how can they assure the best outcome for the patient, knowing that if they're gonna resect a gallbladder cancer and it finally ends as a gallbladder cancer, they may change the prognosis of local recurrence of those patients if they just do the cholecystectomy.
So can you so you call to the OR?
You call to the OR with a mass or polyp. Let's say it's about I don't want to be 3 centimeters. Probably everyone will take it as a gallbladder cancer, and we will assume this is a gallbladder cancer. We'll do everything as a gallbladder cancer. But what happens if this is 1.4 and it is not clear whether it could be something? What would you do?
Well, I guess you could take out the gallbladder and say for frozen, or you can assume that it is and do a radical cholecystectomy right there. I mean, it doesn't have a lot of comorbidity to do a radical cholecystectomy. So you have much more to win that if you do that, if you don't. So that's what I would do.
Do you use intraoperative ultrasound? Does it help to define? I don't know. Does it help for you?
I don't know if I use it, but I don't know if it would necessarily add much at that point. I would incline to do a radical cholecystectomy. Yeah.
Daniel?
Yeah, I think being called in the OR, I think the first thing is really determining if the expertise is there. So if we are called and we are used to doing this, yeah, the expertise is there. The second thing is really determining if we are going to assume that this is gallbladder cancer, is this at a stage that doing the resection would be helpful? And I would also kind of factor in what am I finding this in the process of doing just a laparoscopy? Because if I'm doing just a laparoscopy, I probably will start with an ultrasound. And if I find that there's, for example, liver masses or non-contiguous areas, it may be in the benefit of the patient to stop and do a complete staging prior to proceeding. Having said that, like Dr. Alcejo said, if this appears to be like a 1.34 centimeter mass, I would still do the ultrasound to make sure that it doesn't invade and into the liver. It can help me guide the surgery. But I would probably do a radical cholecystectomy. The ultrasound, it's helped me a few times in understanding, reviewing it from the pre-op studies and intra-op, determining if I'm going to go full on and do a radical, or if I can just do a cholecystectomy and assess this, because it's not uncommon that we see a lot of what appear to be masses in the gallbladder that are not really cancer, adenomyotosis, polyps, things that look like masses and are inflammation, gallstones, sludge, and so forth. So if you can clearly see that this remains in the gallbladder, it's okay to do a cholecystectomy and, during the same operation, open the gallbladder and the table and make sure there is not a mucosal mass. So we do that not very often, but whenever we are faced with, not so much intraoperatively, but just because of the referral pattern that we see. But when we see patients that may come with a diagnosis of gallbladder cancer, gallbladder mass, without having had their resection done yet. So it's oftentimes hard to get a conclusive diagnosis one way or another. So we explore and we have the plan of either doing a radical or doing a cholecystectomy safely and opening the gallbladder on the table and making sure there's not a mucosal mass.
Do you ever get any
service? We use we indicate the cholecystectomy laparoscopy when the polyp is close to the 10 centimeters, 10 millimeters. And the preoperative image included CT scan and resonance, but it's not necessary PET scan, but in this case, next the cholecystectomy is mandatory to frozen.
Eduardo, can I just say one
please,
thing?
please, yes.
I would say one very important thing is to use your preoperative imaging to guide your preoperative counseling to the patient as much as possible to to inform of these possible scenarios intraoperatively. Oftentimes you don't have that opportunity though, because you're getting based on an ultrasound or just an ultrasound in the emergency room, and they're getting a cholecystectomy for presumed stone disease. However, I think the frozen section is sometimes very difficult to assess T stage because it's not necessarily the size, it's more the depth of invasion. And you can have a large IP, a 3 centimeter IPTN that's only mucosal based. So the frozen section, I think, helps you the most to say, is this clearly mucosal based lesion, a T1A that we're not going to do anything? But it's sometimes very hard for them to designate T1B, T2, T3, and you could say, well, it wouldn't make a difference anyway. But if you were suspicious enough to do the radical cholecystectomy and do the 3 centimeter wedge around the liver, then I would do the lymph nodes as well. Again, having talked to the patient's family in the waiting room, because if you're doing the liver part of the oncologic operation, then it makes sense to me to do the lymph nodes as well, so you don't have to come back. In our consortium study, when we looked at the timing, as Danielle had pointed out, the 4 to 8 weeks we found to be the sweet spot in terms of the best results, and that the reasons for that could be very multifactorial, as that was a retrospective study, but part of it I think is there's lack of staging, and so patients who get that initial operation at the time of finding it, there's many of those patients probably have distant disease that we didn't know about because you're doing it based on an ultrasound. You don't have a good MRI of the liver, and you're just based on intraoperative ultrasound of the liver, or maybe those lung mets you don't know about, things like that.
Yes, good, thanks. Dr. McNamara, Danielle talked about residual disease. Does it play any role in the decision-making of adjuvant treatment? Because residual disease is not, when it's not in the lymph node, could actually not change the stage of the patient for an incidental gallbladder cancer. But we know that the prognosis could be worse than by the same stage without residual disease. So does it play a role for you, the residual disease we found in the oncological resection of this incidental gallbladder cancer?
So in resection, I would leave it usually to the MDT discussion and for a decision as to whether they thought it was best to go back in. If I suppose what we would always do
yeah, we have some communication. Hello? Hello? Yes, there you go.
No, it's really.
Mairéad?
will I give?
Yep.
Yes,
Can you
yes,
hear me?
you're here, yes,
Yeah.
yes.
Yeah. So I would always do upfront new baseline imaging, because sometimes in those patients you'll actually see disease and you're treating advanced disease, then not particularly in the adjuvant setting. So it is a difficult one. Usually we'd leave the surgical decisions to the MDT. Then oncological, then if they thought that they weren't going to go back in and there was no residual disease seen on the scan, it is a discussion with the patient whether, chemotherapy in the form of adjuvant treatment is something that you would think about, or whether it's watch and wait and you'd do imaging and treat then once there was obvious disease with treatment in the advanced setting. Because regardless of what you do, I think you are going to be treating patients for advanced disease probably relatively soon. So it has to be an MDT discussion and a discussion with the patient, I think.
Perfect, thanks so much. I have to talk about the non-incidental gallbladder cancer, and I assume that what Eduardo Viñuela final message was before attacking all those advanced gallbladder cancer, we have to understand a better biology of those cancers, and probably chemotherapy will help to do so. Which chemotherapy would you offer a patient who had an advanced gallbladder cancer, locally advanced gallbladder cancer?
Yeah, it would be cisplatin gemcitabine at the moment. You know, here in the UK, durvalumab is not approved yet, so it is cisplatin gemcitabine, or if there was a clinical trial, that's what would be offered here. You know, durvalumab has an FDA approval, but I'm not sure whether it is available in every institution.
Okay. And Daniel, you do have experience in your institution about neoadjuvant treatment. Are you offering neoadjuvant treatment, and which is your regimen for neoadjuvant treatment in gallbladder cancer?
Yes, I guess before we had the opportunity of enrolling patients in trials, we were doing GemCs, and occasionally we're doing GemCs Abraxane. And I'm talking about primarily biliary tract cancers, and GemCs Durva. We're in the process of Dr. Dembo, my partner, is in process of opening a multi-institutional trial with, I believe, with GemCs Durva for biliary tract cancers. I know Shishir, Dr. Michael, who is on the line, is the PI for the opt-in trial. I think it would be nice to hear him maybe explain the schema and the specific regimen and rationale and how the enrollment is going. I think it's very unique that it's focused only on gallbladder cancer. So I think that's the way to go, but the feasibility of doing it, how is that turning out?
Yeah, no, thank you. As you said, it's the way to go, but it's very hard. That's why all of the advanced disease studies are done as lumping trials with all the cholangiocytes and the gallbladder. But then it leaves you to the questions that Eduardo started the whole discussion off anyway, when talking about BILCAP, that gallbladder cancer only comprised 18% of the population. How do we apply it? I mean, in the end, as Dr. McNamara said, you have to apply it based on all comers, and the studies are not powered to that. So enrollment is slow. Again, I think a lot of it, we opened the trial during COVID. And as I was mentioning, the diagnosis of incidental gallbladder cancer was reduced during 2020 and 2021, but I think it's starting to increase now. But it's definitely slow. So we need all the patients that are eligible to be enrolled. And we are making some efforts through the NCI to start allowing, and this is an amendment that's going to go through soon, hopefully, is to allow the standard of care chemotherapy to be delivered in the community. So Danielle, if you have a patient coming from 3 hours away, coming to Moffitt, we're trying to, given that it's GemCis and it's standard chemo and it's just a sequencing question, we're trying to basically put an amendment that they can get their chemo locally and then come to you for their surgery at Moffitt. And I think that will help a lot with enrollment, as I've personally received at least 20 emails about patients who would have enrolled had they been able to do their chemo locally, but we're not willing to travel for the chemo. If you don't mind, just while I'm talking, I'm going to say a couple other things about chemo. The TOPAZ regimen has become a quote unquote standard of care, but as Dr. McNamara knows, I mean, the difference in median OS is 6 weeks in that study. And from a trial design standpoint, if you look at the survival curves for the first 6 months, they're completely overlapped, and then they start to split when the control arm gets nothing and the treatment arm continues to get durva. So it's almost like durvalumab versus nothing, as opposed to GemCis Durva versus GemCis. And I know that immunotherapy can take a little while to act, but really the first 6 months are completely overlapped. And the SWOG 1815 trial is being reported at ASCO GI coming up in 2 months. So it'll be very interesting to see what that trial looks like, looking at GemCis, nab-paclitaxel versus GemCis. And again, even though you're not supposed to compare cross trials, that's what everyone's going to do, is look at the median overall survival between the GAP regimen and the TOPAZ regimen. And then I think, the philosophy of neoadjuvant therapy, this is the last thing I'll say, is, we look at the biologic recurrence rates and the biologic behavior of gallbladder cancer. And as Daniela was pointing out, I mean, many of these patients have residual disease. We know the recurrence rates are high, the overall survival is low. So I think that's the rationale for neoadjuvant chemo, is biologic patient selection. And right now, based on available data for opt-in, that's why we had to use GemCis, because that was our kind of most active regimen at the time when we were designing the study. And with GemCis, nab-paclitaxel, we've actually done some studies in cholangiocarcinoma, but again, it's a little bit harder to do that in gallbladder cancer. But again, without this phase 3 study, it would be hard to do that in the gallbladder setting neoadjuvantly. But I think, as we continue to learn from our medical oncology colleagues, all the advances that are happening in the advanced disease space with GemCis Durva, GemCis nab-paclitaxel, those are things we need to start thinking about using perioperatively, preoperatively, and postoperatively. And also, like, I'm actually designing a cholangio study where we're actually doing targeted therapy. So we're doing NGS preoperatively and trying to do FGFR2 inhibition preoperatively for intrahepatic cholangio. So really trying to extrapolate what's going on in the advanced disease space and bring it forward. And the last thing is, we talk about neoadjuvant. There's neoadjuvant therapy for resectable disease, and then there's neoadjuvant therapy for conversion, right? For patients who have locally advanced unresectable disease, non-metastatic. And I think those are very two different situations, in which in the latter, if you were trying to get the best response and trying to convert a patient from non-resection to resection, then I think you really have to think about the GemCis nab-paclitaxel regimen, because at least in the phase 2 study, the response rates were 45-50% compared to the 25-30% in Topaz. So again, no head-to-head comparison, but all of those things have to go into consideration when you're trying to figure out what your goal is of the chemotherapy before surgery.
Sure. What's the conversion rate from unresectable to resectable with chemotherapy?
Well, it's not very good, but if you look at Rachna Shroff's phase 2 study, again, this is a phase 2 study, but of the 60 patients, 12 converted to surgery, so 20% converted. And of those 12, 2 of them had a complete pathologic response. So, and that was with GemCis nab-paclitaxel. Now, again, that's all biliary tract cancers. It's also including cholangio, so not just the gallbladder cancer specifically. And it was a single arm phase 2. I don't know what that number is going to look like in SWOG 1815 in that randomized phase 3. I don't know.
Yeah, because the Topaz study in the phase 2 for the GemCis durvalumab, the response rate was up to 70% in that. Yeah. But then when the phase 3, the response rate is about 20%. 20. Yeah. So it's a big difference, and you never know until you do your phase 3 randomized. So it will be really interesting to see.
Exactly, yeah. Which is a very common finding. Very common finding. Yeah. The phase 3 doesn't replicate the phase 2 finding.
Exactly. Yeah. But I think it will be important, as you said, about targeted therapy. If you're getting response rates of up to 40% with the FGFR inhibitors, 35%, right. Maybe that's what you should be going for in the neoadjuvant setting, right. Going forward. So these are the things that are going to, I think, come into play as time goes on, and maybe FGFR inhibitors, which are more selective and have potentially better response rates as well, because there are a number of different FGFR inhibitors.
Exactly. Yeah, no, that's exactly where we're trying to go now in the cholangio space. And in the gallbladder space, it would probably be HER2 focused, but in the cholangio space, we've been focusing on FGFR2.
Yeah.
I think with this last question, we could end our webinar. Cecilia, you want to say something to our participant and speaker?
Yes, about the approach to laparoscopic. Is BAEBA is the best indication, but laparoscopic approach, what is the stage and the rare resection, or it's possible the biliary duct resection or vascular resection. What is the best indication to the laparoscopic approach?
Can I say something?
No?
Yeah, I can actually say that I think as a model, laparoscopic approach in gallbladder cancer have to be done in a very specific team group who had experience in minimally invasive surgery. That's the first thing. The second thing, if you are learning how to do gallbladder cancer, you cannot compromise the extension of the resection. So you always have to have some gold standard, and that would be most likely for biliary tract cancer being the amount of lymphadenectomy you do in your minimally invasive surgery. And the third thing I could say is that if you're doing your learning curve of gallbladder cancer, you should start with incidental gallbladder cancer, because those patients most of the time are already randomized by the first resection, and most of the time you cannot jeopardize either the biliary perforation or a biliary disruption of the gallbladder while you're doing the minimally invasive surgery. And in that, having said that, most of the studies that are published are involved in only T2, T1 category of gallbladder cancer. And I think there is very limited experience in T3 type of gallbladder cancer. That's what I can say. I don't know, Daniel, you have any thought process?
I agree with everything you said. What we done here is that we developed a robotic liver program, and we did this in a sequential manner in which really getting to the major hepatectomies and the gallbladder cancers were kind of part in the last phase. And the reason for that, we didn't want to compromise the resection, not so much from the liver standpoint, but from the portal lymphadenectomy. So once we were able to, with the learning curve and the skills, replicate the same approach that I described there that we do often, we do it, robotically, and then we're essentially doing the vast majority of the gallbladders that way as well.
Yeah, that was perfect. I just download the, hopefully it's an open access, cancers. I just download the clockwise lymphadenectomy. So thanks so much. Federico, I think we already are with the time. So
Yeah.
if you want to say the last word, that would
No,
be
I mean,
perfect.
I want to thank all the participants. Thank you, Eduardo, Cecilia, Daniel, Dr. McNamara, Shashir, and everyone who logged in. I think it's a very important topic to discuss because there's a lot, that we should learn more about. And I hope we make progress because it's a terrible disease. Thank you everyone again, and we hope to see you soon again in another webinar.
Thank you. Bye.
Great.
Bye,
you.
Maria.
Bye.
Thanks so much for
Thank
everything.
you.
Bye, Cecilia. Thank you so much.
Bye.
Bye,
Bye.
Cecilia.
Bye,
Bye,
Federico.
Daniel. Thank you.
Thank you.
Bye,
Thank you so
Daniel.
much.